Happy New Year. This is the beginning of our 2021 year. And who knows what this year will hold for us, but hopefully we'll have some good education opportunities. However, this year I'm also going to request that each one of you help me in live presentations of our upcoming 2021 diabetes update. That's going to be entered into BHU very shortly. And of course, it will be required for everybody. But as we know, flipping through slides in BHU is not the answer. So this year, I'm going to have our own educators, our own diabetes staff, and also by virtue of your being Diabetes Resource Nurse Committee, you've been voluntold that you're going to help do live reviews of this update as well. So thank you all for being part of the committee and staying active. And today I'm very pleased to have our very first speaker as someone who is related to me. Some of you name and ask me that. And I'm proud to say this is my son, who's actually triple board certified, currently working as a pediatric intensivist at Joe DiMaggio. And his most recent endeavor is being licensed in CBD prescription, I guess. We don't use the word prescription. But anyway, he's going to explain that a little bit more. And there is a connection, of course, to lots of disease entities and how it can benefit from CBD. But in particular for us, I wanted us to appreciate the connection. And once again, after the program, I'll make sure I have a listing of everybody that's been here, and I will send you evaluations as well. So once again, I'm most pleased and very, very proud to introduce my son, Eric Exelbert.
Hi, everyone. Hopefully you all can hear me. Thanks, Lois or Mom. I feel very honored, obviously, for obvious reasons, speaking to everybody here. I do have a lot of slides, and I don't want to be jumping right into ship, but I do want to make sure that I don't make things any more complicated. But very quickly, my name's Eric Exelbert. I am a full-time pediatric ICU doctor at Joe DiMaggio Children's in Hollywood. I also did have a clinic here in Florida or South Florida in regards to medical cannabis. I've recently joined an endeavor in Massachusetts. I'll spare you the details on how that started with Dr. Kaplan, Ben Kaplan, who started Ced Clinic. And we have sort of launched a pediatric portion of Ced Clinic in Massachusetts where we can do telehealth. And then the clinic that I had down here was Exelbert. But but my mother had asked me to talk about diabetes and CBD, and to be honest, I'm not going to specifically talk about CBD because there's a lot of components to it. But my goal is really to give you guys a tutorial, if it's okay, on just medical cannabis in general, the endocannabinoid system, because to talk about why it's important in diabetes, you really need to understand the system. So my goal of really the majority of the talk, to be honest, is to focus on what the endocannabinoid system is, which I'll get to, what makes up the components of it, at least have everyone understand what cannabinoids, and I'll explain what that word is, exists, that human consumption, or that exists for human consumption. And then I'm really going to take about 5 articles that recently came out in regards to diabetes and the endocannabinoid system. It's mostly in regards to non-alcoholic fatty liver disease, obesity, metabolic syndrome, and then just really one slide of what the medical indications are in regards to medical cannabis in the state of Florida. So without further ado, this is something you guys do much, much more than me, especially with me being in pediatrics. I might not even have described this patient accurately, but at least from when I was an internal medicine resident, this was some of the things that we did. But if I want you to sort of get an idea of a classic patient that you guys see, and think about that when I'm describing everything, and ultimately your questions, and then of course what we get to. But to me, this is sort of the classic person walking around. You've got a type 2 diabetic who's 55 years old. Maybe I didn't choose the best A1C, but that's probably something he's shooting for or she's shooting for. Not even going to tell you if everybody's on metformin, but I know a lot of people are still on it. But for this patient, he is on it. He's on an ACE inhibitor for blood pressure. He's got a crappy HDL. His LDL is too high. He's about average height, which is much higher than, or much taller than me, but that's okay. He's a little bit overweight, and he used to smoke cigarettes. So this was sort of the person that I encountered, at least when I was a resident in North Carolina many, many years ago. He doesn't like taking medicines like everyone else. And then he's got the hallmark sort of findings of a 55-year-old guy. His nerves feel like doo-doo. He's got a lot of pain. He can't sleep. He thinks he gets chest pain, but like everyone else, they want to blame it on heartburn, which is probably not all heartburn. He hates following a diet. And then, of course, he has the same goals as everyone else, losing weight and having less pain. And so this might be the patient that in the future or already has started asking you about marijuana and cannabis. So for those of you who either have lived under a rock or were scared to talk about marijuana or don't want to know what it looks like, this is just some pictures of what the plant may look like. I think what's important is understanding that this is real. There's medicinal properties that comes from it. The pictures are really just to show you that you could be walking along the, hopefully not the street, but in the bottom left, there's no buds or anything on there. Those are just the classic marijuana looking leaves. And then in the other three pictures, you can see a little bit more close up, the bottom right, a bud, what we would call a bud forming. And then in the top right, a little bit of a closer up of the pretty plant, and then a bunch of plants on the top left. I wanted to share this with everyone. When I gave a lecture about 6 months ago, this was sort of what's going on in terms of the country of recreational cannabis, medical cannabis, a pharmaceutical associated program, or nothing at all. I think the take-home message from this is we are obviously in the green. We are a medical cannabis program. There's a lot of green on the picture, but I think what's impressive is that there's very little gray. And gray is where there's no public access at all. So you've got some islands on the bottom. You've got sort of the Midwest in the middle. And then, the top left, but mostly on the West Coast of the US, and then a little bit on the Northeast, is all recreation and medical cannabis. So times are changing. This map will likely, in my assumption, in the next 5 years, all look dark green, or at least dark green and green. But if you showed this map from 5 years ago, it would be mostly gray. Every time I give a lecture, depending on what the lecture is about, and you can see this list is getting longer and longer, but I like to show people what data used to exist. And when I say used to, you can see it's 2017 compared to now. So again, like I showed you, there's a lot of subjects that I've given talks on, most of them related to pediatrics. But if you go towards the bottom, I obviously didn't give any talk on obesity and diabetes and pain. So in 2017, I didn't look that up. But lo and behold, there's really not a whole lot of data in PubMed, which is the search engine that most of us use. So if you typed in cannabis and diabetes, there's only 175 related articles. And then if you add pain to that, there's only 36 articles. Or if you add obesity to that, there's 35. So I'm going to talk to you guys about 5/6 articles. So 1/7 of what's out there. So there's really not a whole lot. And what I'll show you is that it's mostly very basic science or animal models. So it's even less human studies. So let's just jump right into it. The cannabis plant is important because it has over 400 medical compounds. The Latin name for the plant is Cannabis sativa. The biologically active compounds consist of the bullets, phytocannabinoids, terpenoids, and flavonoids, and we'll go through slides of those in a second. When people talk about cannabis, they talk about strains, and you'll hear Lemon Dog, you'll hear Blue Dream. All of those are what's called chemovars. That's the chemical name. And it's basically like if you're looking at different plants or different tomato plants or different roses, they're all roses, but they look different, and the biology or the botany of the plant is different. Chemically, it's a 21 carbon ring. I'll show you a picture. The main cannabinoids, which most people know about, are THC and CBD. THC has a long name, but that's the chemical that causes euphoria and is really the reason why cannabis has been out of the medical world for, since the 30s, because of the concerns. And then of course CBD which started this talk, in terms of my mother mentioning this, is really what's out there, and I'll explain why there's so much out there. We'll go through some of the other cannabinoids. As you can see here, CBN, CBG, THCV. Don't worry about the long names. Just really know that these exist. And I think what's really, really important, if there's a take-home message from this slide, it's that hemp is a sister or a brother, however you want to call it, to marijuana. What differs in it is really a legal description. What I mean by the description is that to be called hemp, you have to have less than 0.3% THC, and that's been instituted by the government. Why is that important? Because it's not called marijuana, it's able to be sold in stores, as you guys all see it. It's able to be sold across state lines. And what's dangerous about that is that unless you check the properties and get what's called a certificate of authenticity, you could very easily be obtaining what you call hemp that has a lot more THC or other things in there. So it's a legal term in the sense of what hemp is, but I think it's really important to understand that it's supposed to have mostly non-THC related cannabinoids, and they can be sold across state lines. And then I think from a last sort of, last sort of data point is that as of 2018, 2.5% of the globe uses marijuana. So that is not, or it is a very significant number. And so if you think about the amount of people that have diabetes or just the amount of people that have any sort of metabolic syndrome, there's a high likelihood that they're already tampering with marijuana in general. This is just for the scientists out there, what the carbon ring looks like. I think, again, what's important from this slide on the top left is that most of the cannabinoids are developed or get broken down from the parent molecule CBGA. So really just very small changes in the chemical, as you know from various pharmaceuticals that are out there, can make huge changes in the activity of the chemical or the drug. So this is sort of the heart of the next part of the plant. I mentioned this in the beginning. There are three aspects of the plant which are hugely important and have to do with why we think the medicinal quality or benefit is taking place. Phyto means plant, so there's cannabinoids that exist from the plant. There's what's called terpenoids or terpenes, which I'll get to in a second. You might have already been getting asked about that by your patients. And then there's flavonoids, which are also another part of the plant. So let's look at those in order. Sorry. So the phytocannabinoids, these are, again, the active chemicals that exist in the plant and are concentrated in the sticky structures that are at the end of the plant called trichromes, which I'll show you on the next slide. What's important about the phytocannabinoids is what determines what's in each plant is by the botany or the genetics. The same example I gave for the roses. What makes a rose yellow versus red? What makes it smell one way versus the other? What makes a human attracted to one rose versus the other? That all has to do with the genetics of the plant. And if we increase the size or get down into a microscopic view, this almost looks like a worm. It almost looks like an animal that's got sticky little fingers on there. That's where all these phytocannabinoids go to or come from. And when you're looking at a new bud, so to speak, that you're picking off the tree, sort of the brightness and the little, when you rub your hands against it, it's got this sort of sticky quality to it. These are what you're seeing here. The terpenoids is the next important part of the plant, and these are really the oils in the plant. This is what gives it the odor. This is what gives it the color. Any plant, tree, flower, anything, when you go and smell it, these are the terpenoids that you're smelling. In the cannabis plant, there's about 200 different kinds, which we'll talk about. The combination of phytocannabinoids or the cannabinoids that we'll talk about, again, that's the THC, the CBD, the CBN, all of those. And the terpenoids helps determine, really what's going on from a chemical standpoint. Some have more, some have less, but again, that all has to do with the botany. What's important about this for your patients is, and I'll get to, is there are terpenoids that exist in other trees and flowers or other products that we use on a daily basis. And that's why things can be, that terpenoids are being now isolated and even put and sold from, you know, in places, you know, like Whole Foods, you know, I don't know for sure if they're in Whole Foods, but places like that, because the US FDA recognizes these as being safe. There's a really, really good, very long article that I have here. Again, I'll send this talk. I think Lois has the talk, my mom, and she'll be able to pass it on to you guys. It's a little bit more than scientific. It's quite detailed, but beta-caryophyllene is a terpenoid. It's found in black pepper. It's why people say put pepper on your foods. But this is a really good explanation of why we think beta-caryophyllene helps in diabetes. This paper literally could be a 5-hour talk. So what I don't want to do is dig deep into it. What I want you guys to understand is that beta-caryophyllene is a type of terpenoid. A terpenoid is a part of the essential oils of the plant, and it can have benefits. And this article is all about diabetes. Here's just the chemical compound, which again, you can, if you picked up and are savvy, is much different than the cannabinoid compound. On the right of the screen, you can see the potential benefits. So if we scroll down to the caryophyllene, which I just talked about, on the left, it says it can be found in black pepper, as I just mentioned. The sort of medical benefits that are discussed are anti-inflammatory, which is obviously very important. Analgesia, very important. Protects the lining of cells, so that could be sort of our endothelium or the lining of our stomach. And then it smells like citrus, or it has a spicy smell. That's just one. There are others, as you can see here, that can help with various different things. If you just look at terpenol is one, but it can be antiviral. So again, these are claims. There is some medicinal science to back a lot of this, but you know, this is again one of the reasons why the plant is exciting and has some beneficial things in there. This is for I guess I'd call it marijuana junkies, or people who have used it recreationally. If you look at the sort of second to the bottom row, those are those funny names that I mentioned. So super lemon haze, lemon skunk. Those are sort of, not sort of, but they're names of strains. If you go to a dispensary, and let's say you're interested in getting a strain of cannabis that is very high in myrcene for whatever reason, because you think it might help you sleep, then White Widow or Blue Dream might be strains that you would go to. And then at the bottom are just some other places where you can find these terpenes. So we're eating and ingesting terpenes all the time. We just don't know because it's never come about. But when we talk about why certain foods have certain medical benefits that come from nature, this might be why. The last are the flavonoids. These are the compounds that give the color. They filter UV lights. It's why certain bugs are attached to plants. Again, this exists in all sorts of flowers. There's about 20 of them in the cannabis plant. This has a different type of carbon skeleton than the other. And again, there's various effects, as I have listed, all along the same pathway of why they may help. Here's the chemical structure again. And then if you look on the right, we're eating a lot of these all the time. Blueberries, are high or anthocyanins. So these are, again, other sorts of foods. And if you look at the pictures of these are all pretty healthy foods. So if you're eating these already, you have no idea that you're getting all of this. But again, when we're talking about a good diet, especially in your patients with metabolic syndrome and just obese, this is the types of things, it's not only just to talk about why these are good just for their diabetes control, but it's also good from all the other health benefits that we're talking about. So the combination of this whole thing of the three things that I just mentioned, all the cannabinoids, if you look at this picture to the right, is something called the Entourage Effect. And the Entourage Effect was described by Dr. Meshulam, who's from Israel. He's considered sort of the king of marijuana. He helped to discover THC and isolate the chemical. And he really is the father of this field. But it's the Entourage Effect means that the cannabinoids work together or work better together when they're isolated from one another. And it's the synergy that enhances the effects or modulates the effects beneficially. So I think the reason why I want to show this slide is exactly the reason why I was asked to give this talk, is that I was asked to give the talk about CBD. And if you look at this map, so to speak, or this picture, it's one, I believe it's a hexagon, but it's just, or maybe it's an octagon. It's one octagon in this picture of this whole or totality of all the things that I just mentioned. So if you take the people who really believe in smoking flower, and meaning, you know, getting the flower, the bud, as I showed you in the first picture, and lighting that, or however else, you know, however you take that, you are getting all of these potential things that are in there. And so it doesn't mean that everyone should have flower, but what it means is that the greater good, or the combination of all of these, is much more important than the independent or isolated chemical that is in this picture. So what does that mean? Does it mean that if you only take CBD, you can't have a good effect? No. Does it mean that if you only took one type of terpene that you can have a benefit or beneficial effect? No. What it means is that that we're learning about all of these things together, and the hope is that sort of the more you have, the better you can do, or the better you will do. And then as we get into now talking about the endocannabinoid system, I think it'll make sense when I get into what's called, you know, this entourage effect. So the endocannabinoid system is complex. If there's another take-home point from my talk today, it's that it's difficult to understand from a biological level. So when I trained in medical school, immunology, which is pretty much now standard of care in terms of T cells, B cells, CD4, CD8, you know, which have to do with the antigens that exist in our inflammatory system. All of that was new, and I remember learning this language as if it was foreign, and now it's just sort of commonplace. I think we're seeing the same thing in what's called the endocannabinoid system. When I describe it, it's complex. You'll see some pictures of it, but it's really made up of 4 different things, or categories. The first is the endocannabinoids. So I just described to you all what phytocannabinoids are. Phyto, again, comes from plants. Endo is the name given to our endocannabinoid system. It exists inside our body, endo meaning inside, and that we actually make, which I'll show you, our own endocannabinoids. It's very important to understand that, because what we're trying to do when we are on the medical side, so what Dr. Kaplan and I do, is we are trying to manipulate the endocannabinoid system using phytocannabinoids to either replicate, reduce, or change the already endocannabinoids that we have in our body. And there's actually a syndrome that we think exists called endocannabinoid deficiency syndrome. And we think that that might be really what fibromyalgia may be, or something along those lines, that the endocannabinoid system is not working properly. But the first and most important category of this system inside of us, again, I'm talking about humans now, is the endocannabinoid system. And all mammals have an endocannabinoid system. The second part are the receptors. When I talk to people about what receptors are, those are basically the doors that open and close. You guys know this from the GLUT4, or you know, the different receptors that are being used in the medications that are all sort of commonplace in diabetes, of which I don't know all of them anymore. But the G protein coupled receptors are what exist in the endocannabinoid system. Then the next phase of this are the enzymes, the proteins, the channels that move through the cell in order to make reactions take place. And then lastly, once you're in the cell, and I'll show you this with a picture, there's the transport molecules that are now taking this process and transporting across the cells. They need to be broken down, they need to be made, or there's byproducts of those that then do other things. But these are the main 4 categories. And if you look at this picture, ignore the left side for a second, because I'll talk about it. But this is basically the 4 different systems, or 4 different categories that exist within our system. And this is just one very quasi-simple picture. On the top right, you can see AEA and 2AG. Anandamide, which is also called AEA, which means bliss, was one of the first chemicals found, and it's very similar to the chemical in marijuana called THC. Again, phytocannabinoid, endocannabinoid. It's called anandamide because of bliss, and as I've told you before, and as you all probably know, the THC can cause, or does cause, euphoria. The second cannabinoid, again, this going back from the last slide, now moving on to now, is 2AG, otherwise known as 2-arachidonyl glycerol, very similar to CBD. And then you get to the receptors. So you can see in the picture the little doors, those squiggly lines. There's Cb1 and Cb2. Cannabinoid 1 was the first receptor found, and cannabinoid 2 was the second receptor found. And then there's some non-cannabinoid receptors that also are involved in the endocannabinoid system. I don't need you to memorize these, I just want you to see it. We'll talk about one of them in one of the papers. Then as you move down to the biosynthetic enzymes, again, you don't need to memorize this, but we know what these enzymes are. And then lastly, the other types of enzymes are the canoes that I talked about. And I think what's really cool about this picture is if you look at the red lines, what's made at the bottom is you can see arachidonic acid, which, as you guys know, is manipulated or dealt with in pain. And if you think about COX-1, COX-2 inhibitors like or cyclooxygenase, which is basically involved in the inflammatory cascade. So again, I'm just trying to show you another way of A, this system exists in our bodies, B, we have a really good idea of what it looks like, and C, it's interacting with other systems in our body, which again, I'll show you some pictures. Another take-home message from this is I just told you about the 2 receptors that exist within our system. Hopefully you guys can all see that there's purple and there's blue. There's the Cb1 receptors, which mostly exist in the midline, and I'll take that a step further. But what I think is important for you guys is that there's Cb1 receptors and Cb2 receptors, all over, but they're both these receptors are located in the pancreas. So if you're just scientifically intrigued, right away you can see that there's things that we're going to learn as we learn about the endocannabinoid system that the pancreas is directly involved with. So again, this slide is going to talk about the receptors that I'm showing here. I'm sorry to bounce back and forth, but I just want you to get an idea again. Cb1 receptors, Cb2 receptors. Cb1 receptors are the most abundant G protein coupled receptors in the central nervous system. To give you an idea, the mu receptors, which is how narcotics work, they're involved with pain, there's 10 times the amount of these G proteins. Again, we didn't know much about this until we discovered the endocannabinoid system. And if you remember from the purple dots on the previous slide, most of these are located in the central nervous system. There is some in the periphery, again, where those purple dots are, but most of the Cb1 receptors are in the central nervous system. The Cb2 receptors, those are the light blue ones. Those are sort of the exciting ones that people think about in the immunological world because of where those are. They're located in immune cells in the brain, which I've listed there. They're located in what we call the peripheral nervous system, which, as you guys know, is everything outside of the spinal cord. So when you talk about peripheral neuropathy, that's the peripheral nervous system. And then if you think about other immune cells, the bone marrow, the liver, the spleen, again, I mentioned the pancreas, that's where the other Cb2 receptors are. And we think that those have various immunosuppressive or just anti-inflammatory actions. The endocannabinoids that we make, the anandamide and the 2-AG, operate differently depending on where you read and what sort of article you're reading. For the most part, anandamide is a partial agonist at Cb1, at Cb2, and 2-AG is a full agonist. But as I'll show you in some of in the talk in these articles, these receptors do a lot of different things with a lot of different chemicals. This is more to just show you when I say that this is a complex topic. This is exactly why it's complex. So you have a very dynamic interface here, which I think is pretty super cool. And so this is really what we call the Endocannabinoid Dome, or sort of the kingdom of everything that regards at the endocannabinoid system. Again, you don't need to look at anything more than the fact that on the bottom, sort of where you can see COX-2, where it says fatty acid amide hydrolase, excuse me. COX-2 is involved with prostaglandin production, and if you look there, CBD, is influential in this area. I think again, the hallmark for this slide is if you look at it and take the time tonight or whenever you look, you'll see CBD, you'll see THC, you'll see receptors all over the place, you'll see serotonin, you'll see dopamine, you'll see all these things, which basically is because this is a very dynamic and interactive kingdom, if you want to call it, or system within our body. This is not meant to be confusing. It's meant to just show you how much we know. So when we think about what's available for us as humans to consume, let's talk about that a little. Again, phyto coming from the plant. So I don't want to go into too much detail, but CBD is sort of one of the hallmarks. CBD is very cool because it doesn't cause euphoria. There's something called allosteric binding, which means that when a chemical reacts with a door or the receptor, it can change the configuration of that receptor to either not work, to allow other things to take place, or really just to sort of overall change the chemical process that's going on. CBD can do that in a positive way, and a negative way. Positive just meaning it allows the door to open. Negative, it doesn't allow the door to close, or it doesn't allow the door to open. CBD also is very good at preventing the breakdown of another type of THC, which can be very euphoric. So most of the THC that we're aware of is a delta 9, if you remember from the beginning. Our body breaks down delta 9 to delta 11, mostly in the liver, and that can be even more euphoric than THC. So when you hear about people who overdosed on edibles or oils, they may be people who can make this transition from delta 9 to delta 11, and can be really schnockered or sedated. Why I'm mentioning this is that when Dr. Kaplan and I talk to our patients, CBD is actually a rescue drug, similar to Narcan is in narcotics. If somebody has taken way too much THC or is feeling way too euphoric, or maybe just schnockered, we tell them to take a large amount of CBD for these exact reasons. THC we just talked about, binds directly to the receptors as opposed to CBD, which I just mentioned. The plants determine how much THC is in there. And some examples of the effects of what THC does to our body is it increases the release of ghrelin, which is our hunger protein. That's why people get what's called the munchies. It can also be anti-inflammatory. It can stimulate apoptosis, which means programmed cell death. And that's why we think high doses of THC may help in cancer therapy, where apoptosis is important. And then in PTSD, it can help us forget things. One of the hallmark findings in patients with PTSD is that they can't forget the trauma. They keep reliving the experience over and over again. And THC has helped with binding in the brain, especially to Cb1 receptors, and has helped to negate or aid in people who have severe PTSD. The others I'm just going to mention because I want to get to some of the rest of the talk, but CBG, CBN, CBDA, THCA, CBC, you can all get these you can ingest them. There are some companies that exist, mostly in California, that have isolated these and sell them independently. Florida's really not doing that yet. However, if you were to get a flower, and if you looked at the ingredients, so to speak, or what's made in there, you'll see that a lot of different percentages exist of these different cannabinoids. These are all the different ways that you can take cannabinoids. I think the most important thing is if you inhale it, you get it faster. It goes directly into your bloodstream, and it doesn't last very long. If you take ingestions or any sort of oral or sublingual, it takes longer, but it can last a lot longer. And then, of course, there's other sorts of ways. There's topicals, there's inhalations, and there's suppositories. There's actually very good data that the suppositories in patients with endometriosis, uterine fibroids, bad hemorrhoids, because of how many blood supplies there is down in the lower GI tract, that you get a lot of effect from suppositories. So let's get into the diabetes part. So all of this but I feel like the introduction is necessary. 425 million people 3 years ago had diabetes worldwide. They're estimating that 200 million more people will have it by 2045. So again, if you think about how many people I told you in the beginning are using cannabis, 2.5 or 3% of that is a lot. They obviously have abnormalities in their pathways of carbohydrate and lipid metabolism. There's a strong association with obesity or elevated BMI, and then the pathogenesis of diabetes. I don't think I need to go through for this group, but I think the reason why I put these in here is because exactly all the things that I talked about the endocannabinoid system is helping in all 5 of these areas, especially with inflammation, mitochondrial dysfunction, and apoptosis. Most of the people that are developing diabetes, and this is probably going to be more of the type 2s than the type 1s, but they have poor diet, they have high calorie nutrient diet, they don't exercise, they're using either recreational substances for whatever reason, or they're addicted or they like it, or they're using other drugs for their other medical conditions, which are also causing problems such as diabetes. All of these things are contributing to the metabolic syndrome and then ultimately diabetes. So what are people doing? Again, you guys know all of these. They're trying to control their sugar. They're trying to use safer drugs. They're trying to limit all the lifestyle modification or changing the lifestyle modifications or limit the risk factors. They're now starting to get into different foods, as we talked about, nutraceuticals, which is becoming big. In the diet related, you're basically getting what's called phytochemicals. So chemicals from plants or vegetables that are helping in your medical lifestyle. And then of course, really the hallmark of why I'm mentioning all these is that because of what we're learning about the endocannabinoid system, the endocannabinoid system is being looked at as a possible therapeutic target for drugs, which I think is the future of cannabis, which is a whole another discussion. But if you remember that picture I just showed you of all the interactions that are going on, drugs do the same sort of thing. They're looking at one enzyme or one door or one pathway and then trying to make a change in disease. So of the 35 to 36 articles that I mentioned to you guys, these are sort of the most recent articles. I took a few of them, but basically there's a case study of a heroin addict who had something called, which I'd never heard of before I looked this up, diabetic neuropathic cachexia, but it's basically a case study who was a heroin addict and it helped with his disease. Obviously there's a lot more articles about pain and neuropathy. There's articles about non-alcoholic fatty liver disease, which I'll spend a couple of slides on because there's 2 articles on that. Obviously, if we're talking about inflammation and metabolic syndrome, there's talks about stroke, and then as you move down. But these are really from in the last 3 years or 2 years, what's out there. So I just wanted to bring up the article that started this conversation with my mom and I. I did ask her to send this to all of you. I didn't want to spend too much time just talking about CBD because this article is about 15 pages. It does a really, really good job of talking about the different effects of CBD. I want to just mention it because I would encourage you to read it, but there are a couple of articles that I will discuss that are mentioned in this article, but it's a really good sort of general gestalt talk about endocannabinoid system and then CBD in regards to diabetes. And then what they talk about is in that article is sort of how it works. And I just want to show you this picture of the different receptors that CBD is working on. And I really want you to focus on the bottom. And they mention, how it affects the liver and how it affects the heart and how it affects fat cells and of course the pancreas. And I'll get into this a little bit in regards to the articles, but this is sort of what's out there in regards to CBD. It doesn't mean that everybody who takes CBD is going to have these effects, but this is at least gives you an idea of where they're working, why they're working, and what it might do, at least in regards to CBD. And this comes from that article. So the first article I'm going to talk about is related to obesity and non-alcoholic fatty liver disease. So what I did on all these slides is I gave you the name of the article. I really don't want you to focus on every single word I wrote. And then I gave the boldface so that if you go back or if you look at the article, you can see. This article really wanted to look at a high-fat, high-cholesterol diet in mice, giving different cannabinoids, and then identify some parameters of non-alcoholic fatty liver disease. So they had 5 different types of mice. They had a normal diet, not given any cannabinoids. They had a high-fat, high-cholesterol diet, given no cannabinoids. And then they added CBD to these diets, THC to the diet, or a ratio of 1:1 of THC to CBD. And the goal was looking to see any parameters of the metabolic syndrome that were changed using different cannabinoids. What's cool about this whole thing is that the mice that got cannabinoids and had a high-fat cholesterol diet overall consumed less food than the normal diet group. And that continued throughout the study. That's important if you just think about one of the problems in obesity is what they're eating and how much they're eating. So even with a bad diet, they ate less of the bad diet. What's also interesting is that in the THC group, again, that's the euphoric part of the plant, it completely ameliorated non-alcoholic fatty liver disease. So again, still given a high-fat, high-cholesterol diet, their fatty liver disease went away. The CBD-rich extract did not have the greatest findings in this particular study. It showed increased fasting glucose levels, which of course we don't want, and it had an increased inflammatory marker. So my take home from this is that CBD didn't help in this group. And then the cool thing about the mice that had fatty liver disease went away in the THC group, their fat content went down. They might have gained weight because they were on a high-fat diet, but their adipose tissue weight went down. They had improved glucose response, and their overall liver enzymes, which is seen as to be elevated, went down. And the cool thing is that they also measured insulin levels, and the insulin levels didn't change, but their glucose response changed, which shows you that there might be something to do with the sensitivity. So the take-home message from this is that there might be a relationship, but the mechanism of why this happened, it was hard to tell from this particular study. Another study, which was in gastroenterology, this is a little bit older, in 2012, they were really looking to see, specifically looking at the cannabinoid receptor 1, or the Cb1, in the liver. The title is Hepatic Cannabinoid Receptor 1 Mediates Diet-Induced Insulin Resistance via an inhibition of insulin signaling and clearance. Basically, the background to this article is that we know that obesity-related insulin resistance contributes to cardiovascular disease. Blocking Cb1 does improve insulin sensitivity in obese animals and people. And we know this because there used to be a drug, I might say it wrong, Rimonabant or Rimobant, which was taken off the market in 2008, but that was a Cb1 antagonist. It blocked the receptors. And those people lost weight and they had better glucose response. Better insulin sensitivity. It was taken off the market because they had serious psychiatric problems. So the background to this article was that they knew there was a drug that blocking Cb1 can help with insulin sensitivity. We also know from previous studies that some of the cannabinoids that exist inside of us, our endocannabinoids, are elevated specifically to AG, and we can see that those human beings or people are developing non-alcoholic fatty liver disease, which I just talked about. So what they showed in this article was that the mice that specifically had just the liver Cb1 knocked out, it didn't block them getting obesity, but it did block them from getting non-alcoholic fatty liver disease and insulin resistance. So again, this is a little bit like the other article that I told you about, where patients still got fat, unfortunately, but they didn't get fatty liver disease and they didn't have insulin resistance. And so, again, looking at specifically CB1. In this next article, the background to this article, so this was basically looking at the GI tract. So as I mentioned to you, there's receptors in the GI tract as well. The GI tract is sort of a big deal now, not only because of just what we've already known it does, but related to the fact that the GI tract has a lot of bacteria, and it's supposed to be involved a lot in our inflammatory cascade. And so they wanted to look at specifically, if you affect the cannabinoid receptors in the GI tract, what can that do to sugar load? So the background again to this is that there's Cb1 receptors expressed in the GI tract. The Cb1 receptors there are hugely involved in the regulation of the motility, which I'll get to. That's sort of the hallmark variable in this study. And it's not necessarily involved in what's absorbed. What I mean is really the speed of how things are moving through the GI tract, because there's data that exists that by how fast things are moving through might affect how things are absorbed, might affect our satiety levels. So that's what they were specifically looking at. And it's known that type 2 diabetics, obviously from gastroparesis and other things, have a disturbed GI motility. And what they were able to see, let me just get down to the bottom here, that there was a decrease in action in these receptors. So I'm sorry, I didn't mention, they gave anandamide, which is one of the endocannabinoids, again, this in mice. And what they showed was that the motility decreased in things move. So they were able to measure the motility in the GI tract, which made these mice more full. But it also showed that their postprandial glucose levels were lower. And so they don't think that this has to do with a change in how they were absorbing the glucose, but they think it has an effect on the speed of the way glucose is moving through the GI tract. And so, again, looking at Cb1 receptors, looking at the GI tract, knowing that the GI tract is altered in diabetics, and they were able to see that there was an alteration in the GI tract transit time, which affect postprandial glucose levels. The next couple of articles are really related to the receptors. This one was a very nice review article. It's just why the endocannabinoid system might be a potential target for treating diabetes. I think the third bullet, if you move down where it says increased endocannabinoid system tone, there's data to show that when the endocannabinoid system is heightened, which we see in metabolic syndrome, and especially in diabetes, that there's issues with the Cb1 receptors, as I just talked about. And the issues cause people to eat more. And this is exactly what I said in the last article. They have a higher palate for foods that aren't good for them. All of this makes us have more energy storage. All of us makes us have more body fat. And so what they showed in this article were that there was markers of insulin resistance so insulin resistance correlated with the upregulation of Cb1 in fat cells. And so independent of BMI, when they were looking at just the endocannabinoid system in general, another article that was talking about how insulin resistance might not have anything to do with the obesity, but it might have to do with the upregulation of these Cb1 receptors. So again, I'm just giving you another sort of viewpoint on how they looked at the endocannabinoid system and how even though insulin sensitivity, obesity, and all these things are interrelated, there might be more going on in this endocannabinoid system that may also help in therapeutic targets. Now, this looked at the endocannabinoid system in general. This looked at the endocannabinoid system mostly in regards to fat cells. The previous article where I told you about Cb1 was primarily looking at liver cells. And so again, it's important to understand that what's happening in one part of the body is not necessarily happening in the other part of the body, even though the system is similar. And that's what makes this so complex. And it's what makes all of our dynamic physiologic systems complex because of the interactions with all our different organs. This last article was looking at two different cannabinoids, specifically looking at CBD and another type of cannabinoid called THCV, or tetrahydrocannabivarin. It was looking at glycemic and lipid parameters in type 2 diabetics. They basically either received CBD or THCV alone or in combination at different ratios, with the hypothesis being that some of the effects of cannabis may be from the agonism or antagonism of CB1. Again, focusing on CB1 because of where they were. But they were specifically looking at the HDL. And then they had all these secondary parameters. What this article showed that CBD alone didn't show any of the parameters that they were looking for. So no change in HDL, no change in any of the other things. But what it did show was a decrease in a chemical called resistin, which I didn't know existed until this article. But resistin is a chemical that exists that accelerates our body to make more LDL. So the good thing about CBD is that it decreased this chemical. It didn't cause any of the primary or secondary outcomes. And it also increased what's called the GIP, or the gastric inhibitory peptide, which actually is very insulinotropic, and it has some preservation or preserving properties in the beta cells. So CBD did have some positive things, which would be good for your population of patients. What's really cool is that THCV significantly reduced blood glucose levels, improved the HOMA2B cell function. I'm not sure if that's a model you guys use anymore, but it's called the homeostasis model assessment. But anyway, THC reduced fasting glucose, improved 3-hour glucose response, and there was really no difference in insulin response. So that's important because it was showing, again, maybe there's other mediators for glucose just from the receptor. Unfortunately, there was no change in HDL. I'm going to skip the last two for the interest of time, but these are just two other articles that just have to do with the interaction of our endocannabinoids and other receptors that exist in diabetics, and why we think that overall using these as markers may help in the disease. This is just a cool slide looking at all the different potential properties that cannabinoids have and that may affect different things. So as you can see, CBD has the most claims, so to speak. This is an old picture. I would be willing to bet that it's changed. I used this picture probably 3-4 years ago when I started talking about cannabis. I would be willing to bet that the blue of CBD probably is still that big, but the others might be a little bit bigger. In the state of Florida, just to now move on and sort of conclude, these are the conditions that are legally allowed to get a medical marijuana certification. It's probably important for you to know that diabetes is not listed there. However, if you look at the number 12, in Florida, a medical condition of the same kind or class that's comparable to one of the listed conditions qualifies. For example, a autoimmune disease like Crohn's disease, number 8, Crohn's disease is an autoimmune disease. If you have a medical condition, i.e. another autoimmune disease, which diabetes can fall into, especially type 1, ulcerative colitis, lupus, so all rheumatoid arthritis, that would be a situation where I would need to prove to the state that you compare to an autoimmune disease like Crohn's. So the state has basically opened up a can of worms by allowing a lot of other diseases to come in, which to me is appropriate. I just wish that it was like in Massachusetts where I'm starting to work with Dr. Kaplan, where basically if we feel that the benefit outweighs the risk and there's medicinal benefit, we can go ahead and recommend a patient. I think the other important part is number 11, which is the chronic non-malignant pain. Pain is probably the most common reason why people are using cannabinoids. And basically it can't be related to just regular old, I don't feel good, I have pain. You have to also revert it back to one of these conditions that I list here. So let's go back to diabetes. Diabetes is an autoimmune disease like Crohn's disease. Patients who have diabetes have pain, thus they would qualify for a condition in the state of Florida. So just to conclude, the cannabis plant has a lot of chemicals that can be used, that can be and are being used for medicinal benefit. The endocannabinoid system exists in all mammals and is a vital and necessary system for individuals to function and live. The endocannabinoid system is complex and dynamically interactive with all of our physiological and organ systems. CBD and THC are the main cannabinoids, but as I've mentioned to you, there are others. Because cannabis is a Schedule 1, the research is extremely limited, therefore, or i.e. exactly like what I told you guys or showed you the articles, that there's barely any, and half of those or most of them are in animals. The data supporting cannabinoids or cannabis for diabetes as a treatment is limited. I think it's important to say because I think that that's the hallmark answer we unfortunately have to give. But you could say that about anything that patients come to see me with cannabis, probably except epilepsy. But I think the hallmark is that as we learn more, like hopefully I tried to teach you guys a little today, that there are potential benefits and there's really not a lot of harm. I didn't even go into potential side effects. I didn't go into drug-drug interactions because that's a whole other talk. But there's really limited or no adverse effects. And I think it's very important for you to know that there's no Cb1 and Cb2 receptors in the brainstem. And the brainstem is what controls our breathing. So unlike morphine, where people who overdose stop breathing, that will not happen with cannabis unless something else happens. Like if you had a seizure and you stop breathing, or you drank alcohol, or you took narcotics. So I think it's very important to know that you cannot really overdose. And there's really not been a death directly contributed to true cannabis flower. I'm not talking about synthetic, I'm not talking about something else that has caused death using cannabis or marijuana. This is sort of exactly what I just said, limited trials. There's very encouraging research, as I tried to describe to you, mostly in animals, evaluating the endocannabinoid system. And I think what's exciting to me is that the insulin sensitivity and the postprandial glucose levels and the non-alcoholic fatty liver disease, I mean, that's pretty cool. That's pretty important information, since all of these things are really being seen in your population. This is just a general gestalt about how we've been able to learn a lot about the system, and that pharmaceutical drugs are being sort of developed this way. And then last but not least, the clinic that I joined in Massachusetts is called the CED Clinic. I would encourage you to go on there for several reasons. Dr. Kaplan has put together a link with probably the largest in the world database of cannabis-related research articles. They are, people are constantly dumping things in there. I just want to give him kudos and credit for that because there's so much in there. Of course, he's been doing this for the last few years, which is one of the reasons why I'm excited to work with him. It has a lot of YouTube videos. This is a YouTube video. This is going to be put on YouTube. So before you ask questions, or if you don't want your face to be seen when you ask the question, just so you know. But there's just a lot of information in this clinic, and then there's a little bit about Dr. Kaplan and I there too. So I know that was a lot of information. It was a little bit of a difficult talk to try to give you guys as much detail out there. I hope you feel that there's data there to at least support you in being interested in it. And then of course, just knowing about the botany for those, interested in the plant. So with that being said, I'll stop. Sorry, I went a little bit over. And if there's any questions or comments, I'll be more than happy to answer.
Thank you so much, my dear. I just see now a comment, wonderful information, so much to look forward to in the future of medicine, which is true. If we ever thought we were dealing with a disease entity that was confusing, now we know all disease entities are even more confusing now that we know more about the endocannabinoid system. And it certainly, again, thank you for being so informative. Are there any specific questions? I will, in fact, ask that you email me if you did, in fact, hear the talk today so that I can send you an evaluation. I can also make sure you're on the list for your credits. And I can send you both this PowerPoint and the article that I had forgotten to send you before, that Eric and I started this whole conversation about more than a month ago. So,
I have a question.
Sure.
Hi. Hi there. I was curious about the well-known appetite stimulation with cannabis and how that plays into, 'cause I missed half of your lecture, so I'm coming in a little late. But I heard you say that it decreased your not your appetite, but the GI system, and so keeping you full longer. But do you have any data on that appetite stimulation, better known as munching?
Yeah, so one of the articles that I talked about was that in the high fat, high cholesterol diet, where they were specifically looking at, I believe it was THC and CBD, that despite getting the cannabinoids, that they were gaining weight, but they were, that they were eating less. I think some of that has to do with just how the endocannabinoid system is working. So we do know that because of where the chemicals work, most specifically THC in the brain, that it's releasing ghrelin, which is that chemical that sort of gives us the hunger. That's sort of one of the reasons for why people take the cannabinoid product,
Marinol.
Dronabinol, Marinol, for like AIDS wasting disease and stuff. And so, but the reason why this is working is because of what's getting released second to where they're binding into the brain. So the data is just more in terms of that we know where, again, it's really THC that's sort of going to these receptors and tricking us into feeling hungry, and it's releasing this chemical. Obviously, people, can continue to eat when they're on that. I think what I was trying to show, which was a little bit different than your question, is that in patients who have metabolic syndrome or are already eating this, really bad diet, that when they added endocannabinoids into their system, that they started to eat less, probably because they were overall feeling better and the endocannabinoid system was changing. But on the flip side, to exactly your question, I mean, some of the kids that I see who have malignancy and are just not able to eat with their chemotherapy, THC, but even CBD specifically has been able to improve that. And I think it's because of where it's binding into the brain. Does that answer your question?
Thank you. Yes, thank you.
I have a question here about addictive qualities. Can you take CBD for a while and then stop and feel like you absolutely need more? Does it have addictive qualities?
So the hallmark statement that, at least for most of what I've read, is that really cannabis is not addicting. However, it doesn't mean that you can't become tolerant, or it doesn't mean that you can't become wanting to use it more. In terms of your question, can it be addicting? My answer to most people is that there's no data really to show me that it is. I think what people say in relation to that is that cannabis is the gateway drug, which I also disagree with, meaning that if you start using cannabis, that your body's going to sort of get used to this type of feeling and you're going to experiment with other things. I wouldn't call that addiction either. I would call that as, being interested. In terms of being tolerant, The answer is absolutely. The endocannabinoid system can sort of plateau in terms of how you massage it with various chemicals. So there are many patients where we give what's called a holiday, where they might be on, XYZ cannabinoid, and they've had some benefit. Now they're either plateauing or they're not seeing the benefit. So there's various options that you can do in that situation. You can go up on the dose, although I didn't get into it, but there's a very belief in a biphasic approach that you could have too little and you can have too much, and it's finding that middle ground. So sometimes you, of course, have to go up because they have become tolerant or the system has sort of plateaued. B, there's an entity of discussion about resetting the endocannabinoid system. So the receptors have been activated, they're sort of been working, but they've plateaued. They're not really making any changes anymore. And so if you sort of trick them into stopping it, letting the body sort of slowly respond again, and then reinitiating cannabinoids, that might help. So sometimes what we'll do with patients is we'll say, hey, for this week, depending on how much they're taking, maybe take half the amount you're taking, or maybe even stop, again, depending on how much benefit versus not benefit you're getting and the reasons why you're taking it. And then you sort of reset the endocannabinoid system. I mean, I can tell you personally, when I would take CBD for sleep, I found sort of a nice sweet spot. Again, that depends on what type of CBD you're taking. And again, that's a whole nother discussion. But I got to a point where it wasn't really giving me much benefit. So I stopped for about 4 or 5 days, was able to restart. And I actually only needed 15 milligrams when I restarted versus the 25 that I was on before. So that there is a tolerance you can have. There is a reset of the endocannabinoid system you can do. And then but I don't think addiction is something that I would characterize. Now, look, if people are doing it recreationally and love being high, I mean, that's a whole different question. If you want to be high all the time and you're addicted to that feeling, if you want to call it, that's different. That's somebody who I think is abusing it as opposed to using it to manipulate the endocannabinoid system. I have no problems with recreational cannabis. My interest in this, and I think that's why Dr. Kaplan and I are working together, is really, we feel that there's medicinal benefit and no harm that can be done for a variety of diseases based on all the data that I've given you. And that's sort of our focus. But I don't think there's any addiction from the medicinal side.
Another question that I see here in the chat, are you available for referrals for patients who may have questions about cannabis?
So that's a good question. So I just finally, I think I just screwed up my screen. I apologize. So I just recently got my license back here because I was medical director of one of the companies here. So right now I'm focusing on my gig with Dr. Kaplan, but I am looking to, take back patients, or not take back, but start seeing patients again. My mother can provide an email, which I didn't, and I'm more than happy to answer questions. I think in the next few months, hopefully, I'll have the ability to start seeing people here, depending on what umbrella it's under. But yeah, so for right now, I'm certified. I'm able to do it, but I'm waiting for, to get this launch, to get what Dr. Kaplan and I launched. But hopefully, it should be soon.
Eric, what CBD do you recommend for insomnia?
Oh, without me throwing people under the bus, that's a tough question. I'll throw out a few companies. So I guess my answer, I will try to answer. My quick answer to you is that just anybody who wants to try CBD or whatever they're getting, number one, you want to ask for what's called a certificate of authenticity, or a COA. And every reputable company should either list it on their website or should be able to give it to you. And it's basically showing you what's in the plant, showing you the percentage of what you're asking for or what they're telling you is there, showing you that there's not too much THC in there, and then lastly, that there's no pesticides, chemicals, or other things that are been placed in there. That's really, really important. And there was a study that actually, they took not tons, but they took a large amount of companies that were stating that they have hemp-based CBD, and there was a lot more THC or other things in there that they were not claiming, which might have been giving the medicinal effect. So jumping off that comment, locally there's a company, and I don't receive any money from them, but locally there's a company called GAB, or Global Advanced Botanicals. Their office is in Coral Gables. Their hemp is from Colorado and Oregon, excuse me. I have most of the patients that I was seeing, I was sending to. Locally, Green Roads, I was sending patients to a long time. They're located in Davie. Most of their hemp is from Colorado and Kentucky, although that was several years ago. And you know, they've grown. They're one of the largest CBD companies in the world. California has a couple of really good products. I use a lot of Miriam's Hope personally, and because they've just been very generous to me. Again, I don't receive any money from there, but they have a lot of isolated cannabinoids, meaning they have just CBD. They have CBD mixed with CBDA. They have just CBDA. They have just CBG. They've been very kind to my patients and giving a discount code, and they've actually recently been very kind to Dr. Kaplan and I, and even starting a compassionate use program, which is exciting. You know, those are the three sort of off the top of my head. I could sit and give you a lot more without, you know, and that doesn't mean that these are the only three and they're my favorite three. That's just what's popping up. But because what you'll find is different CBDs, the milligrams might be different. It's not like when you go, and what I tell patients, it's not like when you go to the store and you buy Tylenol. You know, whether you get the Publix brand Tylenol or the CVS Tylenol, you're getting acetaminophen, but you can't say that with CBD or with cannabis. And the other important part of that is remember that this is a plant. So every plant is different. So if you're isolating CBD from one type of hemp plant or cannabis plant, just because of the botany or the genetics that's in that plant, you might respond to that differently than a CBD from another company. So even going back to my mom's questions about tolerance and all that stuff, there are some times where we say to patients, hey, maybe we've gotten the most out of this strain or this company, or maybe, you know, maybe we got to try a different one. So not all CBD is the same.
Makes sense. Thank you.
Sure.
Thanks everybody for the comments, and I agree this was a most informative talk. So this started off your year of 2021. So here's the story. We give you good credits and wonderful talks every month, and then you give us something back in helping us promote the new diabetes update and keeping up all of the quality controls that we expect out on the floors. So thanks so much, folks. Don't forget, email me, even if you've just now reminded me in a chat that you're online, you know, that you've come to the program, email me again so that I can then include those attachments to you and make sure that you get your evaluation. Thank you so much. And to my dear son, thank you so much for a great talk.
All right. Thank you, everyone. Have a good day.
Have a great day.